So, angiotensin receptor blocker is very important for preventing the AAS induced kidney disease, kidney damage, and also for hypertension for normal population, for normal people. But there are some factors that might also, we know some of those do play a role of the effectiveness of drug, like half-life, right? Patient compliance is very important. When a patient swallows their pills like 2 days on, in 2 days on, 1 week on, 2 day on, 1 day off fashion, in that fashion, they're not going to control their blood pressure as good as taking it every day on the same hour. So half-life also plays a role. When you have a drug that has higher half-life, let's say higher than 12 hours, the chances are you're going to need to dose it twice a day is very, very low. Also, AT1 selectivity, when it binds to AT1 receptor more strongly or prevents the AT1 or AT2 in higher fold, let's say 6,000 fold over 1,000 for other drug, the end result can be superior. Also, of its surmountable antagonism. I'm gonna talk about that in later, just a couple minutes later. And also bioavailability of drug, interaction with other drugs, metabolism, and excretion route of the drug affects how it works. Also, there can be other beneficial effects we haven't mentioned yet. Let's take a look about the images I've talked about. Telmisartan seems to have the longest plasma half-life. So that's +1 for Telmisartan. And let's take a look about PPAR gamma activation for ARBs. Again, Telmisartan has partial PPAR gamma activity, PPAR partial PPAR agonists. It's not as strong as pioglitazone, but rosiglitazone also, it's not as strong as rosiglitazone, but it has some PPAR activating properties. Also, let's take a look at how insurmountable antagonisms how much insurmountable antagonism Telmisartan has. Let's take a look at that. And we see that it has higher insurmountable antagonism than losartan, irbesartan, and valsartan. You might see some research that say that irbesartan has higher insurmountable antagonism than valsartan. Or the same can go with the Telmisartan and EXP3174, which is the active metabolite of losartan. The telling that active metabolite is not technically right, because losartan is in itself is active enough. But some metabolites of the losartan can act even better than itself. So when we take a look at the bioavailability of the AT1 receptor blockers, we see that telmisartan, again, doesn't have the lowest bioavailability. It gets excreted 100%, almost 100% by your by liver and feces, and it has very high lipophilicity, so volume of distribution is very high. It has the highest volume of distribution among the among all the ARBs. It doesn't go through extensive CYP metabolism, and it has insurmountable antagonism. So if you wondered what insurmountable antagonism is, this picture is going to help you a lot. Losartan has the lowest, and you might read that it also has itself, not the metabolite EXP. It doesn't have insurmountable antagonism. So when you increase the serum concentration of angiotensin II high enough, you might prevent losartan's AT1 receptor blocking properties. But when you introduce an animal, like the animal, just say the metabolite of the losartan EXP, which has insurmountable antagonism, even if you increase the angiotensin II concentrations even higher, you won't get AT1 receptor stimulation higher. There is a reason, because it has insurmountable antagonism properties. And let's take a look at the candesartan, which has the highest insurmountable antagonism property. When you introduce candesartan in the highest concentration, as you can see, even if you increase the angiotensin II levels, AT1 receptor stimulation won't even get higher. It stays lower. So it can be helpful in anabolic steroid users who will get elevated angiotensin II and blood pressure. It might be beneficial for them to use an ARB that has insurmountable antagonism property. So, as I've said, telmisartan is one of a kind. It has the longest half-life. It has relatively higher insurmountable antagonism. Is a partial PPAR gamma agonist. It has higher bioavailability. Doesn't have the highest AT1 selectivity, but definitely higher than losartan. Its partial PPAR agonism seems to help with insulin sensitivity, also weight loss, lipid profile. It helps with your lipid profile, increasing the HDL, decreasing the LDL, and decreasing the serum fatty acids. It seems like it browns the white adipose tissue into we call browning into the beige fat, which has more mitochondria. It has higher uncoupling protein levels. Also, it seems to help decreases the visceral fat, decreases the central obesity, and although, as I said, it decreases the body fat, it decreases the central obesity. Anecdotally, it seems like it selectively at least decreases the central obesity, which might mean that someone might lose their body fat mainly from visceral tissues. So that might explain that why some people report that they don't lose their body fat as quickly as it used to be. Also, I want to introduce a new different concept that, as far as I know, nobody has mentioned ever. We know that AAS upregulate the renin-angiotensin-aldosterone system. A low dose angiotensin, a low dose ACE inhibitor or ARB when let's say a medical doctor prescribes, the low dose ACE inhibitor and ARB hold promising potential for preventing this deleterious effect of angiotensin II and thus harmful effects of steroid. Let's give an example. An individual who weighs 190 pounds, let's say he began his AAS cycle. He has no hypertension, no hyperlipidemia. His blood pressure is 110/70. His blood glucose is 80. It seems like very healthy individual. It doesn't use any other drug or doesn't have any other underlying disease. Under a doctor's supervision, he might use a low-dose ACE inhibitor and ARB to minimize the harmful effect of the AAS while not lowering his blood pressure, even if it stays 110/70. Also, he might increase the dose if his blood pressure rises. It's the easiest thing, probably the easiest thing to get prescribed. You go to the doctor's office and they check your blood pressure and it's higher, and he prescribes you an ARB or ACE inhibitor, and they are dirt cheap. So what's gonna happen in, let's say, over the course of next 4 or 5 years, when he progressively increases his lean body mass, also body weight, and weights he uses in the gym, and his drug intake, eventually it's going to increase. So he will likely eventually, over the course of years, he might need blood pressure medications off cycle, because body weight seems to the primary reason of hypertension. Your body don't care much about if it came from your skeletal muscles or fat. I said there is not much difference. There is a difference, but it's not that big. So let's say he used 10 to 20 milligrams of Telmisartan under doctor's supervision on cycle, and off cycle he doesn't even need. His blood pressure is 110/70, constant, doesn't change. A couple years later, let's say 3 years, he might need 30 milligrams of Telmisartan on cycle, and his blood pressure is 110/70 in off cycle without drugs, so he doesn't use. And let's say 5 years later, he might need, if he has higher blood pressure, he might need even you might even need ARBs in off cycle, and you might need, let's say, 40 milligrams of telmisartan on cycle. So now you learned that a microdosing ARBs can prevent many things. Also, it can also help AAS user, recreational user, to control their hematocrit easier, because angiotensin II receptor blockers seem to decrease the hematocrit levels also. And that's all. As always, I highly encourage you to take a look at the research I've cited, and please read those, take a look at those. As always, till next time, take care. Have a great day.